Hello, good afternoon, and welcome to today's webinar. My name is Lori Smetanka, and I am the Executive Director of the National Consumer Voice for Quality Long-Term Care. We're glad to have all of you with us today. While I believe most of you are familiar with our work, for those of you who are not as familiar, the Consumer Voice is a national advocacy organization that represents consumers and issues related to long-term care. And next slide, please, Libby. Our work consists of advocating for policies that support quality of care and quality of life and are responsive to the needs of those receiving care and services. We also work to empower and educate consumers and families, provide training and support to other advocates, including long-term care ombudsmen, and promote the critical role of direct care workers and best practices in the delivery of quality care. Next slide, please, Libby. A few housekeeping items before we begin today's program. First, you heard at the beginning that today's webinar is being recorded. The recording and resources that we're talking about today will be available on the Consumer Voice website at www.theconsumervoice.org. And they'll be posted within the next couple of days. We'll also be posting links in the chat to the resources and materials that are being talked about today. If you have a question for the speakers, please use the Q&A feature on your control panel, and we will select from them at the end as time permits. And then lastly, please use the chat feature on your control panel to respond to questions that may be posed or to interact with other attendees. So as we move on to the topic for today, and the next slide, please, Libby. On June 29th, the Centers for Medicare and Medicaid Services released revised guidance for nursing home surveyors based on the 2016 revisions to the Medicare requirements for participation for nursing homes or nursing home regulations. This guidance is used by state oversight agencies when surveying and assessing nursing home compliance with the federal regulations. When the 2016 regulations were released, they were implemented in 3 phases. Phase 1 was implemented in November of 2016, Phase 2 in November of 2017, and Phase 3 in November of 2019. This recent guidance that we're talking about today addresses Phase 2 clarifications and technical corrections, and it also covers new guidance for the Phase 3 requirements that went into effect in 2019, and it also includes guidance on pre-dispute arbitration requirements, which were part of a separate set of regulations that were passed in 2017, I believe, or what implemented then. So today, our special guests are representatives from the Nursing Home Division of the Quality, Safety, and Oversight Group at the Centers for Medicare and Medicaid Services. The Nursing Home Division is responsible for the programs related to protecting the health and safety of nursing home residents, including the survey and enforcement process. And it is also responsible for the public reporting programs, such as the payroll-based journal staffing reporting program, the Nursing Home Compare website, and the 5-star quality rating system. So we're delighted to have with us today the Nursing Home Division Director, Evan Schulman, who many of you know and have heard before on our programs. And he's also brought with him today several Nursing Home Division team members, including Dara Graham, who is a nurse consultant, Sheila Haynes, also a nurse consultant, and nurse consultant Sonora Jones and Amy Casal. And they have been working on the guidance that we're going to be hearing and talking about today, as well as work on the different guidances related to the long-term care survey process, the COVID guidance that we've all been living with and working around the last couple of years, and all of the guidance that is in Appendix PP. So with that, I'm going to turn it over to Evan, who's going to get us started, and he will direct us through with the rest of his team. So thanks so much, Evan.
Thank you. Thank you, Lori. It is really a pleasure for us to be here. I want to start by, of course, thanking you and all of your members for your advocacy. Advocacy to state agencies, to legislators, state legislators, federal legislators, and then agencies like us. I also want to thank all of the families and friends of nursing home residents out there every day who are advocating to individual nursing homes for the health and safety of their friends and loved ones. And of course, I got to give a shout out to all the ombudsmen out there who are doing this as part of their volunteer work or other work to help keep residents safe and protect and keep them living in an environment where we can work to improve their quality of care and quality of life. So thank you for all of your tireless efforts. Wow, there is so much going on in the nursing home space. You don't really have to look too far to stumble across something that impacts our nursing home world and our nursing home residents and quality and safety. I'm so pleased that our team members will be here today to talk to you about some of the more recent things that we're doing. I wanted to just level set a little bit and tell you some of the things that we won't be talking about today, just so everyone understands what we're going to be discussing. With so many things out there, things like the White House initiatives to improve quality and safety in nursing homes that was also referenced in the President's State of the Union address. That's not something we're going to be talking about today. In that, there's reference to a staffing study and potential minimum staffing requirements. Also, we'll not be talking about that today. There's also proposed rules that have been released, such as the skilled nursing facility PPS rule that still is under development. And of course, our partners over at the CDC have a lot going on related to guidance for how we manage COVID in our daily lives. We are working with all of our partners on all these things, but we're here to talk about something a little bit different today that touches these things, but is not those exclusive things. So our team will be going into that in a little bit. There are a couple of things that I do want to mention just at a high level. One of the things that we can talk about is the 5-star rating system. As Laura mentioned, that's one of the areas that our division oversees. And I want to make sure everyone is aware that we recently announced the methodology that will be used to include new staffing measures in the staffing rating system. Back in January of this year, we released new staffing measures on nurse staffing on weekends, and also turnover of nurses, turnover of registered nurses, and turnover of administrators, all of which appear to be linked to higher quality of care. Well, we posted those measures for consumers to look at and review in January, and now we're including them in the rating system come next week on Wednesday. And this will give consumers a more comprehensive view of the level and quality of staffing that is existing in each facility. So we're really excited about that. We are happy to answer questions about that. Another thing, I know I mentioned that we're not really here to talk about CDC's guidance, and we're not, but I do just want to make sure everyone still keeps their game up on protecting us and our loved ones from COVID. COVID has been increasing. Number of cases have been increasing slightly over the last few weeks in nursing homes. So we still need to keep our guard up. That means following the CDC recommendations for masking, hand hygiene, and physical distancing. And most importantly, stay up to date with your vaccinations, everyone, please. That is the most effective way to protect ourselves from severe disease. The vaccinations have proven to prevent hospitalizations and death over those that aren't up to date with their vaccinations. So please make sure that you're up to date with your vaccinations, follow CDC guidance, and we'll all together continue to protect ourselves, our friends, and our family from COVID. With that, I'm going to turn this over to Sonora Jones, who's going to lead the charge in walking through some of the key points of the new guidance that was just released a few weeks ago. And then we'll be happy to answer some questions afterwards. There were some questions that were, I believe, were submitted beforehand that we'll be able to answer, but we'll look through the Q&A and try to answer some questions on the fly later on. So Sonora, I will turn it to you.
Thanks, Seven. On June 29th, CMS issued a QSO Memo 2219, releasing a large body of long-term care surveyor guidance that further supports the implementation of the revised long-term care requirements for participation, which was published in 2016. This guidance clarifies specific regulatory requirements and provides information on assessing compliance. In addition, CMS is revising its guidance to state agencies to strengthen the management of complaints and facility-reported incidents. These revisions will be incorporated into the long-term care survey process and begin to be surveyed on October 24th, 2022. This advanced release allows surveyors and nursing home providers to review the training and become familiar with the changes. Our team will now share some of the significant changes in this release, and we'll start with Sheila Hans, who will begin to give a summary of significant changes for the first topic, which is abuse, neglect, and changes related to Chapter 5 of the State Operations Manual. Thank you, Sheila.
Thank you, Sonora. In these revisions for abuse, neglect, and changes to Chapter 5, we clarified expectations for compliance, abuse reporting, including a sample of reporting templates, and provided examples of abuse that, because of the action itself, would be assigned to certain severity levels. Additionally, we streamlined the guidance by removing one F tag for abuse reporting and combining the information into other abuse reporting F tags. Specifically, we deleted F tag 608 and integrated that guidance into F tags 607 and 609. With 607, we added policies and procedures related to the allegation of retaliation by the facility against a covered individual. And at 609, we added policies and procedures related to reporting of crimes. Additionally, we added a table of examples of reporting abuse allegations and suspicion of crimes. We revised guidance in Chapter 5 and related exhibits of the State Operations Manual to strengthen the oversight of nursing home complaints and facility reported incidents. We revised timeframes for investigation of complaints to assure that serious threats to residents are investigated immediately. CMS will work with states on implementation of this. And we also revised guidance for all Medicare certified provider and supplier types to improve consistency across the state agencies in their communication to complainants. Now, our next area is admission, transfer, and discharge. Here we clarified requirements related to facility-initiated discharges, added guidance related to leaving against medical advice to ensure facilities do not force, pressure, or intimidate residents into leaving, clarified a facility's requirements when a resident's Medicare coverage may be ending, but the resident continues to need long-term care services. And we provided new guidance for when a facility alleges they cannot meet the resident's needs and does not allow a resident to return from a hospitalization to ensure an inappropriate discharge is not occurring. And now I'll toss it over to my colleague, Amy Casal, to continue.
Hi, thank you, Sheila. Hello, everyone. To continue, we have also added guidance in a couple of areas to address residents experiencing mental and health and substance use disorder, which includes the rights and the behavioral health services for individuals with mental health needs and substance use disorders, how facilities should address potential substance use issues while still adhering to resident rights, and how to address supervision of residents who may leave the facility and use illicit substances. For nurse staffing and payroll-based journal, or PBJ, we revised guidance using payroll-based staffing data to trigger deeper investigations of sufficient staffing and added examples of non-compliance. Additionally, PBJ data directs surveyors to investigate potential non-compliance with CMS nurse staffing requirements, and nurse staffing guidance was enhanced with additional guidance and deficiency category examples. For resident rights, we imported guidance related to COVID-19 visitation memo, which enables maximum visitation. We also have addressed the issue of potential inaccurate diagnosis or assessment by clarifying expectations for situations where practitioners or facilities may have inaccurately diagnosed or coded a resident with schizophrenia in the resident assessment. For pharmacy services, new guidance clarifies the requirements pertaining to psychotropic medication that are not classified as antipsychotic, antidepressant, anti-anxiety, or hypnotic medications, but which can affect brain activity. The psychotropic medication requirements apply to other medications, such as anticonvulsant medications used to treat schizophrenia and other disorders, when these other medications are being used as psychotropic medication. Lastly, new infection control guidance related to the infection preventionist has been added. The guidance explains how the infection preventionist role is critical to mitigate infectious disease through an effective infection prevention and control program, while the requirement is to have an infection preventionist at least part-time. The infection preventionist must meet the needs of the facility, which may warrant the use of an infection preventionist full-time. Additionally, CMS and the CDC have collaborated to create free specialized training for infection prevention, which is available on the CDC website. I will now turn it over to my colleague Sarah for additional information.
Thank you, Amy. In the area of arbitration, we wanted to note that the new binding arbitration agreement requirements went into effect on September 16th, 2019. This new guidance clarifies that residents may be offered arbitration agreements, but they cannot be required to sign them as a condition of admission or condition to continue to receive care in the facility. Furthermore, we want to highlight that the Psychosocial Outcome Severity Guide revision clarifies the application of the reasonable person concept and severity levels for deficiencies, including how to determine the severity of the outcome when the impact on the resident may not be apparent or documented. Additionally, other phase 3 requirements such as trauma-informed care, compliance and ethics, and quality assurance performance improvement, QAPI, as well as the clarification of quality of life and quality of care, food and nutrition services, and physical environment are included in this guidance. Also, CMS Memorandum QSO 2219 included recommendations related to resident room capacity, but there are no new regulations related to resident room capacity. However, CMS is highlighting the benefits of reducing the number of residents in each room, given the lessons learned during the COVID-19 pandemic for preventing infections and the importance of residents' rights to privacy and home-like environment. Lastly, CMS released training resources in the Quality, Safety, and Education Portal, QSEP, for surveyors and nursing home stakeholders to explain the updates and changes to the regulations and interpretive guidance. And that concludes our update of key long-term care surveyor guidance changes. I'll now hand it over to Evan Schulman.
Thank you, Dara, Sonora, Sheila, and Amy. So just a couple of comments here before we get to some of the questions. Number one, you just heard a very, very high level description of the key pieces of guidance that were released a couple of weeks ago. There's a lot more details in there. So very, very high level. Number two, even though I just said it's high level, you also heard technical terms like FTAG and Chapter 5 and Phase 3. We live in a very, very technical space when it comes to nursing home regulation, and it's just something that's inherent in our world. While we can't always get away from these terms and sometimes have to reference them because that's the world we live in, the thing that I would stress is that we've gone to great lengths through our guidance to be able to have these terms be translatable to surveyors so that when they get a complaint in from someone on the ground, a family member who has no idea what an FTAG is or what Phase 3 is or what Chapter 5 is, but they just know that something's wrong with mom. And we've made our guidance so that when that call comes in, then that survey agency translates that allegation or that complaint into the right area of our guidance so that it can be effectively investigated for compliance or non-compliance. So it's very complex. It's part of our world, but we do understand that we're not expecting consumers to call in and say, well, I think there was a violation of this facility with FTAG 725 for my mom. No, but we do receive complaints and would know that if someone calls and says, I don't think that the staffing is appropriate or sufficient for my mom, that survey agency would know I need to investigate FTAG 725. So with that, I think we're going to go to questions, Sam, and our team is on the line to answer some of the questions here.
Great, great. Excuse me. Thanks, Evan, and thanks to your team. We really appreciate it. So we obviously had some questions regarding the guidance. I guess we could start off around some visitation questions. Many of the people on the call today who are watching and Consumer Voice, and obviously you really know how hard it was in those early days of the pandemic when facilities were locked down and residents were not able to see their families. And it went on for a long time. And in the regulations, the right for a resident to meet with the family members is clearly stated. It's only subject to the right of the resident to refuse that visit. The idea of imposing other considerations on that doesn't really come in. Yet in the guidance, CMS does say that the right of the resident to see a family member is subject to health and safety considerations. Obviously, we don't think any family member should just come in there and not follow proper infection control. But how can you reconcile that with the regulations regarding the family visitation?
Hi. So there are other areas of the regulation that do allow for reasonable limitations on visitation based on the health and safety and infringing on other rights. With that said, we've gone to great lengths to ensure that visitation should be occurring for all residents.
Okay. Can you talk a little bit about any steps that CMS has taken, to prevent this type of visitation shutdown in the future? God forbid there is another pandemic, but I guess our concern and many of our members' concern is a repeat of what happened to residents. For many residents, the lockdown was even harder than the pandemic, the COVID aspect of it itself. And just wondering, in addition to some of the new things in the guidance, has CMS thought about or taken any steps to address that issue?
Right. So, our priority is the well-being and safety of our elderly population, and we will continue to work with CDC to ensure best possible psychosocial and physical health outcome in any situation. We will do everything possible to not restrict visitations, and we will do everything we can to not go backwards with this visitation situation.
Yeah, and Sam, if I could just chime in a little bit on this one too. Amy's 100% right, and I'll add some more context from from our perspective. The second most heartbreaking thing of this pandemic has been the separation between family members and residents. And I've said that before, the first most heartbreaking thing being the deaths. When the pandemic first started, we didn't know much about COVID. The world didn't know much about COVID. We didn't know how long it would last. We didn't know everything we know now about how to prevent transmission or reduce the risk of transmission. But as we learned, there were different points in the pandemic, we kept on issuing guidance to increase visitation. And we're at a point now where we're not only saying that visitation should be available to everyone, it should be maximized. And while we can never predict the future, we will do everything we possibly can to not have any visitation restrictions at any point in time in the future. So it's something we feel very passionate about and something that we're going to keep our eye on.
Great, thank you. We appreciate that passion. Next question. We were really heartened to see the new guidance on the crime reporting, from 1150B of the ACA. And I just was wondering if you could give just a bit of an overview of some of the terms. What is a covered individual? What is a reasonable suspicion of a crime? Are there penalties for not supporting the crime? And what are the duties? And again, you don't have to get into all the meat and potatoes of it, but the duties of state surveyor when enforcing this section of the guidance.
Right. So a covered individual is anyone who is an owner, an operator, an employee, a manager, an agent or contractor of that facility. And a reasonable suspicion of a crime, what it is these are crimes defined by each jurisdiction, such as a state and everyone is expected to know what a crime is in their locality, right? While crimes are defined by each jurisdiction, we believe that this should not be difficult to know. We're referring to the things that most people know could be a crime, such as abuse, neglect, and misappropriation of property. If there's a suspicion of that crime that has occurred, it's expected to be reported. Are there going to be penalties? Yes. Failure of the facility to ensure the reporting of suspected crimes would result in noncompliance and may be subject to applicable enforcement remedies and penalties. And the duties of a surveyor to enforce this section, well, CMS expects state surveyors to investigate and document the failure to develop and or implement policies and procedures for reporting suspected crimes and cite any non-compliance appropriately. Also, the guidance was revised to instruct surveyors of situations where covered individuals in the facility had not reported a suspected crime to law enforcement. Does that help?
Very much so. We were very happy to see that in the guidance it was included that state surveyors themselves are required to report should it be discovered that a covered individual hasn't. So we thought that was very strong guidance. So thank you. Evan, did you want to say anything, or do you just want to go on to the next question?
I think Amy covered all of it. Unless there are additional questions on this, we can move on. Thanks.
Well, thank you. Obviously, as you indicated, there were some updates to the transfer and discharge portions of the guidance, particularly one that comes up a lot for us, and I think for ombudsman, or when facilities allege that they can't meet a resident's needs. Here, there was additional guidance saying that state surveyors need to investigate these situations where facilities discharge a resident because of that. Could you discuss that a little more, what the guidance requires?
Sure. So there may be times when a facility cannot meet a resident's needs. An example of that would be a resident that is transferred to a hospital due to respiratory issues, and then is placed on a ventilator. And when the resident is ready to be discharged, they can no longer be discharged back to the nursing home because the nursing home does not have ventilator capacity, and they don't have that. So they can't provide that care for them. So there should be a notice of discharge, and which explains to the facility that they cannot meet the current needs, and that would be on that situation. There are situations where a resident is discharged directly from the nursing home due to being unable to meet the resident's needs. The nursing home must meet all the requirements for discharge, such as documenting the attempts to meet the resident's needs. They have to find a way of trying to meet the needs, if not attempting to procure those needs for that resident. Also, surveyors should be following guidance for admission, transfer, and discharge. The new guidance addresses types of discharge which could be non-compliant and contains examples of discharges which violate federal requirements. Also, the critical element pathway for hospitalization and discharge are survey tools which help the survey team determine through medical record review and interviews whether there is a non-compliance related to that discharge.
Yeah, and Sam, if I could chime in on this one too a little bit. I can't stress enough what a complex issue this is. Something that we here at CMS are very concerned about and are continuing to look at. The example that Amy gave is a very good example of a situation where a facility would need to transfer someone to a hospital, but then really just it would not be in the patient's or the resident's best interest for them to go back to that facility because they cannot provide the clinical services that are needed. There are other examples where someone is transferred to the hospital and the facility absolutely should take them back and can and should try to meet their needs. I also want to highlight that even then, it's not always that simple. We know that there are instances where facilities have received discharges from hospitals, but the discharge summary doesn't have the full description of what is going on with this individual, their diagnoses, their underlying conditions. So it's a very, very complex issue. But so it's something that we're looking very closely at, and something that we want to address as much as we possibly can. And we'll continue to work with ombudsmen on this, who are big partners, and we rely on them for a lot of information on this. And we'll continue to work with our CMS locations and, of course, the state agencies on this. So it's very complex. A lot of times we get asked the question from sometimes facilities, are you saying I can't discharge someone? Well, from a law perspective, they can, but there are requirements that they need to meet. And our role is to make sure that those requirements are met. And if they're not met, that the individual is not discharged and the facility it remains compliant by meeting those individuals' needs. So I just want to add those notes about how complex of an issue this is.
Thanks, Evan. And we also appreciated how CMS, there was additional guidance added about the Medicare notice of non-coverage, and when that is supposed to be provided 2 days prior to when the facility expects the Medicare will no longer cover. But we appreciated that added language that the Medicare notice is separate from the rest of the discharge process. And oftentimes I think residents get confused because they or facilities portray the Medicare notice as a discharge notice. So we appreciated that added guidance as well. Lori, I'm going to toss it to Lori. I think she has a question from that came in from the Q&A.
Sure, we have a number that have been coming in from folks that are listening in. So let's just pick one or two of these. One is, can you explain how all these new policies are being introduced to facilities? Someone mentioned these seem like a lot of changes, and how, what's the best way for facilities to, and others that are listening, to get more information about what's been implemented?
Yeah, it's a great question, and we wanted to be very thoughtful about how we implement this guidance. And to be realistic, we would not expect facilities or surveyors to be able to implement this guidance overnight or even quickly by anyone's definition of quickly. So we released the guidance we did a press release, we released our CMS memorandum that has all of the notice and all of the information about the changes to the guidance while the existing guidance is out there. At the same time, we released training, and I think, Laura, you pasted the link to the training and the guidance in the chat for facilities and surveyors to look at. So we're giving facilities and surveyors a few months to review the information, become trained, and implement actions to implement the guidance, which could be changes to their policy and procedures, could be changes to their admissions agreements, could be multiple types of subsequent trainings. So the guidance will begin to be surveyed for on October 24th of this year. And over that time, facilities should be gearing up, should be getting trained and taking those actions to make sure that they're compliant. At the same time, we'll be working with survey agencies to make sure that they are ready to survey for compliance on that date.
Thanks, Evan. Someone asked, I think there was a reference to a reasonable person standard in what someone said, and so they'd like to hear more about that. Maybe provide a hypothetical example of how a surveyor may apply that to a situation.
Great, and my team may want to follow me up on this, but what we have to think about a reasonable person, what I think about it is, when someone can't communicate what has happened to them, either because of cognitive impairment or perhaps they've expired, a reasonable person needs to look at that scenario and say to themselves, well, what would a reasonable person view this as? So this can be applied in two ways. It can be applied in terms of physical harm or psychosocial harm. So someone may not be able to tell how or to communicate how much something hurts or what the pain is like, but we should know from a reasonable person's perspective how what that pain is like or what the actual physical harm was. From a psychosocial perspective, we should know, I think everyone knows of the attention that through this country that we've paid to preventing bullying, for example, online or amongst our youngsters. Same thing applies here, that we know that psychosocial harm can come in the way of intimidation, but also other forms of bullying or verbal abuse. So we have to look at it from how would a reasonable person respond to these things when the person that they are being imposed can't always communicate the actual impact that the action is having on them. Team, feel free to add anything to what I said. Okay. Thanks, Laurie.
Sure. Another one is, with the emphasis on using the payroll-based journal data to trigger some areas of enforcement, is there any thought on how surveyors will handle the lag in PBJ data versus conditions on the ground?
Yeah, another great question here. I do want to clarify that the PBJ data is not going to trigger enforcement, it's going to trigger investigation. So just, again, I mentioned we live in a technical world, so we're a little bit sticklers for some terms sometimes. Look, in almost every type of data collection system, there is going to be a lag. Even the shortest lag, which I say is on the COVID data that we post, which has a little bit less than a 2-week lag, there is still a lag. So any sort of data collection system, there's going to be a lag, but there are a couple of things that we can still do. We still have the actual dates, for example, where there was low staffing, and we can investigate what happened, what happened on those dates, investigate, who was there a registered nurse on site or not. And then we also have indicators. We have indicators where if there was low staffing reported for over an entire quarter, even though that time has passed, we can still investigate and use that to ask probing questions of residents, of ombudsmen, of other of the resident councils of what has been happening over the time that is outside of the survey window, or when the surveyors are there, that could have had an impact on their care. So again, there's always going to be some lag when it comes to data collection and processing it and then making it available for use. But we can use that data to either ask poignant questions about specific pieces within the data, or as triggers to investigate what may be happening globally in the facility.
Thank you, Evan. Sam, why don't I turn it back over to you for questions?
Sure, thanks. Evan, in a couple places, the rest of your team, this issue of inappropriate or incorrect schizophrenia diagnoses comes up. I think we know a lot about that issue as advocates, but I was wondering if you might discuss it a little bit more and why it's in the guidance now.
Sure. As you know, schizophrenia is one of the 3 exclusions for the antipsychotic medication quality measure on the 5-star quality rating system. So there are some facilities that are potentially coding residents with schizophrenia when a comprehensive psychiatric evaluation that meets professional standards and/or the necessary symptoms for this diagnosis is lacking. Of course, coding residents with schizophrenia who are also on antipsychotic medication causes these residents to be excluded from the residents counted on the long-stay antipsychotic quality measure, potentially inflating their star rating. Yes, CMS has been concerned about this issue for several years and has conducted focused surveys to examine antipsychotic usage and the appropriateness of schizophrenia diagnosis. We are actively working on this issue and at this time cannot provide the number of nursing homes where this may be occurring. However, ours and others' research shows that while there are some nursing homes engaging in this practice, it is not the majority. We like to note that this issue is also a part of the new White House initiative. As a result of these practices, CMS has added new information to the survey process that helps guide surveyors to better investigate when an individual may have been inappropriately given a diagnosis of schizophrenia and is also given an antipsychotic medication unnecessarily.
Yeah, and I'll just add a couple of things on this one too, Sam. You know, we here at CMS have been very concerned about this, and while we released guidance to surveyors on helping them investigate this issue, there are other things that we'll be happy to update you on down the road that we're doing on this. So we're not just taking one action on this. We're looking at a variety of actions, and this is also a complex issue, but the thing that we always make sure that we want to stress here is that there is this is not about CMS challenging a practitioner's, physician's, nurse practitioner's diagnosis after a comprehensive clinical assessment. This is CMS saying there has been no comprehensive clinical assessment, yet there was still a diagnosis of schizophrenia coded in the minimum data set of the resident assessment. And to code someone with that diagnosis is simply unacceptable. And what's even more so worrisome is that they're on these drugs, which are very, very dangerous to individuals who are elderly and certainly with dementia. So we definitely have heard you all, and thank you again for your advocacy on this. We're going to continue to look at it, and this is just one action that we're taking, but the agency is very concerned overall about this.
Thanks. Just to follow up on that a little, I would imagine you would want surveyors to examine whether there's a history too of schizophrenia. I mean, generally, people in their 60s, 70s, 80s don't just develop schizophrenia for the first time. Is there any requirement that certainly there could be an evaluation, but I'm wondering if there should be some surveyors should look for some sort of history of that prior to their admission into the hospital or to the nursing home.
Yeah, I mean, I'd encourage you all to review the guidance on that, and we'll be continuing to provide more information. But the surveyors are basically going to look for, did the practitioner follow the standard of practice for diagnosing someone with really any condition, not just schizophrenia, but in this case, schizophrenia. So that's what they're going to be looking for. It's sometimes there is a history, sometimes there isn't a history. But I think what we would say to that is a history of the word schizophrenia being, from our perspective, being in the medical record, that actually isn't enough for us. There needs to be the comprehensive clinical assessment following professional standards that documents the behaviors and the practitioner's official analysis leading to that diagnosis of schizophrenia.
Great, thanks. I want to shift gears a little, staffing here. In posting, the CMS posted updated guidance regarding the requirement that staffing information be posted daily in nursing homes. And of course, we applaud that. Did CMS consider requiring facilities to post staff to resident ratios when you are updating the guidance? Something that oftentimes is more informative to family members and to residents. Sheila, I saw you come on.
Yes, I did. Thank you. I can explain a little bit more about the PBJ requirement. And the requirement is for facilities to submit staffing data. Has actually been in existence for years, and CMS is now using this data to help alert the surveyor of staffing concerns. This information, along with the revised critical element pathway, which is used to evaluate sufficient and competent staffing, will assist the surveyors in identifying and investigating potential staffing concerns.
Okay, thank you. Another question. The requirement is 8 consecutive hours of RN coverage per day. In the guidance, there is a hypothetical where it says that facility routinely only had 7 hours of RN coverage per day, but no actual harm to residents was identified. Why is this a no harm deficiency when the potential for actual or harm or immediate jeopardy is so high?
Surveyors need to investigate the non-compliance and the impact on resident health and safety for each specific scenario. So while the absence of an RN each day for 8 hours would constitute non-compliance, surveyors would still need to identify the harm to residents as a result of that non-compliance. And Evan may wish to share a little bit more also.
Yeah, I mean, I think Sheila, you got it right. The first step is identifying was the standard met, was there non-compliance or was there compliance? And that's what the surveyor has to do. There are no, automatic assigned scope and severity levels. The surveyor then needs to be able to link that non-compliance to the harm to residents. Is it possible that that the absence of a nurse for 1 hour a day could have led to harm? Yes. And in fact, if the surveyor does identify that, for example, a registered nurse, that there was an emergency and they needed to call a registered nurse who wasn't there, and because of that, the person was sent to a hospital and had other issues, then yeah, that would be harm. But if they can't identify harm, well, then yeah, then it is potential for harm, but it is still non-compliance.
Okay, thank you. I'm going to toss it back to Lori. She'll answer a couple more questions that came in over the Q&A.
Okay. So one question is related to transfer discharge. Will investigations be triggered by all transfer discharged based on inability to meet residents' needs, or only those identified in a resident sample, or that are brought to a survey agency's attention via a complaint? So I guess, for when a facility is saying they are discharging based on inability to meet a resident's needs, which are going to be triggered for investigation?
I'll ask someone. I'm not sure. Oh, the question just disappeared.
Oh, sorry.
All right, hold on. No. I'll find it. I found it. So our folks, there may be someone else from our team who can talk about this, but I don't think that we can say that all transfer discharge are going to be investigated on every survey based on the inability to meet needs. I'm not sure that there's an actual code for inability to meet needs. Rather, we take a sample of those who were transfer or discharged, and then look to see, well, what was the reason for their transfer or discharge? Now, that's on standard surveys. Now, on complaint surveys, if someone is alleging that someone was transferred and that they discharged and they shouldn't have been, well, then the survey agency would investigate the individual that the allegation was about. Team, did I misspeak at all there, or any other thoughts? Lori, can I check off a quick question?
Sure.
Someone asked, what is PBJ? PBJ, not to be confused with PB&J, and I wasn't here when it was named, but it stands for Payroll-Based Journal, which is the staffing data collection system that CMS has implemented, which requires nursing homes to submit staffing data electronically to CMS, and that it is auditable back to payroll. So prior to 2015, we did not have this staffing data that was for every day of every person working in a nursing home, but also was not auditable. The payroll-based journal data is the most robust staffing data of nursing homes in the country, and that's what PBJ stands for.
Thanks, Evan. Another question that's one that we see a lot with respect to transfer and discharge is when a person's Medicare benefits are coming to a close or are ending. And I know this is addressed in this guidance. Can you clarify again, when a person's Medicare benefits are ending, that does not necessarily trigger a discharge, or is a facility required to give a notice of involuntary discharge and 30-day notice at that point? Could you talk a little bit about what should happen there?
Well, I will say, I'm going to ask our team to step in here if they can. The end of the Medicare benefit does not automatically result in a discharge, because the person may have other needs that are not covered by Medicare. But team, anything else that you can add to this? I lost the question again. We may need to follow up separately, Lori, on that one.
Yeah, it's if Medicare benefits are ending, does the nursing home need to give an involuntary discharge or 30-day notice?
I don't have that one yet in my memory. Anyone from the team?
This is Bonnie with the Division of Nursing Homes. I could just add, Evan, to what you were saying. It wouldn't require a notice of discharge, but it would require a notice to the resident that their Medicare benefits were ending, and therefore there may be some additional finances or payment or another means that would need to be used to provide payment for the stay if needed. But just the notice that the Medicare benefits were ending.
Sure, thanks, Bonnie. So it's possible the person would switch to a different payment source.
It's possible, and we're happy to follow up with some additional detail if needed.
Yeah. Someone had asked about having a little bit more information about behavioral health and substance abuse aspects and what surveyors would be looking for with respect to those areas.
Yeah, this is a tough one. That's a very broad question. Well, first off, let me say that year after year, we hear more and more about new admissions to nursing homes of a population with a greater needs for mental health care and also substance use disorder. And even if you do not work in the nursing home space, you can see that these are two issues that have been increasing in our country in every setting. And as an aside, there's been more attention and a little bit more of a spotlight put to this through the pandemic. And I hope that causes all of us as a society to pay more attention to this. From a nursing home perspective, we have been seeing an increase of individuals year over year that have significant mental health needs and substance use disorder. And what we've had to do is to give facilities guidance on how to navigate some of these situations. For example, if a resident wants to leave a facility, the facility cannot stop someone from leaving a facility. They can advise the person that they should not leave the facility, but they can't really stop them from leaving the facility. Also, when they return to the facility, we would expect the facility to be able to identify signs and symptoms of substance abuse and potentially have to improve or provide increased monitoring of that individual. Also, we're encouraging providers to get training so that they understand the triggers that could be associated with drug abuse and prevent or be ready to respond to an overdose. But also we have to remember that nursing homes are not drug treatment centers, and substance abuse disorder is a disease, but it is an underlying disease. And we actually don't expect nursing homes to cure people of their substance use disorder. So it would not automatically, for example, be non-compliance if there's still an overdose in a nursing home. However, we do expect nursing homes to use their best efforts to try to prevent the overdose. But if it does happen, then to address it immediately and be prepared to care for that resident right away. So it's a very, very complex issue. One that spans much broader than just the nursing home space. But we're really trying to balance the requirements related to resident rights, what a resident is allowed to do, what a facility must allow the resident to do, what a resident has a choice to do on their own, but what we also expect the facility to do to try to help protect and keep that resident safe.
Thanks, Evan. One that we hear again a lot about that is covered in the guidance is related to a resident who's been transferred to a hospital and the requirement of the facility to take them back. Is that a transfer or a discharge? And what is the expectation about being able to go back to the nursing home?
Yeah, I'll start and someone can finish if I miss something. it starts as a transfer. So when someone gets transferred to the hospital for, say, an acute change in condition, that is not a discharge, that is a transfer. If the facility then determines that they cannot meet this person's needs and they cannot take this person back, it then is no longer a transfer. It then falls under the discharge requirements. And there are very specific requirements that facilities must meet in order for this to be a compliant discharge. For example, documentation that the facility can't meet this person's needs, or documentation and the reasons why, or documentation of the attempts that the facility made to meet this person's needs. So it starts as a transfer, can be a discharge. We can't say 100% of the time whether or not it is a compliant or non-compliant discharge. Every single situation needs to be investigated on its own facts. But regardless, every single discharge must meet the requirements for discharge in order for it to be a compliant discharge.
Thanks, Evan.
Sure.
And I'll turn it back over to Sam. We have about 5 minutes left, so we probably have time for 1 or 2 more questions.
There is new guidance, as you said, regarding arbitration agreements, the use of arbitration agreements in nursing homes. These are agreements that oftentimes nursing homes ask residents to sign either at admission or at another time, which states that a resident would forego taking the nursing home to court, but rather enter into private arbitration agreements. I think you know how we feel about the use of these agreements, and we were glad to see CMS include language about how these can be confusing and probably should not be used necessarily at the time of admission if the resident is in crisis. And there was also some really good guidance to surveyors. Could you talk a bit more about what surveyors should be doing to ensure that residents, when they sign these agreements, know what they're signing, and that the use of these agreements are compliant with the regulations?
Thanks, Sam. So when surveyors perform a recertification survey or a complaint survey, surveyors will then conduct interviews and record reviews after verifying the use of agreements in the facility. Regardless of whether there is a potential non-compliance or not, interviews and record reviews will occur in facilities that have offered agreements to residents to determine compliance. Thanks.
Great.
Thanks, Darren. And I'll just add onto this one. And I know, Laura, this may be a good place to stop, but we also agree with you, and that's why CMS finalized a rule that prohibited nursing homes from requiring arbitration agreements as a condition of admission or a condition to continue to receive care. And there's other requirements too, such as making sure that they're understood. This is the first time, though, that surveyors have had to survey for something like this. And surveyors are great. They're great clinicians, but they're not lawyers. And these things can be difficult to identify. I'm sure some agreements, it will be very easy to see in black and white if they're compliant or not. And others, we'll have to take them back and keep looking and maybe revise our guidance. And we would look to Consumer Voice to help us as you learn of what's happening in facilities. We'd be happy to take a look at agreements to help us monitor how this is being surveyed as we progress. So, but thanks for the question. It's the first time that this has ever been surveyed for.
Thanks, Evan.
Thanks, Evan. And thanks to Evan, and thanks to all of your team members who joined us today, both on camera and presenting, and those who were working behind the scenes to help answer questions. As you saw, there have been a lot of questions, and we barely scratched the surface. And then we were trying to focus most of the questions related to the issue that we're presenting to you today, which is the guidance that has just been released. But there are a lot that have addressed a lot of other issues, and Evan will circle back around to you related to some of those, and try to work with you on getting answers to those for those of you who participated today. So thanks so much for joining us today. And for all of you, thanks for joining us as well. As I mentioned, the recording and the materials that were linked in the chat will be posted to the Consumer Voice website within the next day or so. And that again is at www.theconsumervoice.org. So thank you so much and have a good afternoon.
Thanks for all your hard work and advocacy.
Thank you.